Hello, hello. Welcome, everyone. My name is Monica Ruiz, and I'll be your moderator for this session. We're excited to dive in today. But first, here are just a few quick items. Uh, Please feel free to reach out to me directly if you need assistance. You can message me by going on the top right corner. There's a chat bubble in blue. You can go ahead and look up my name and send me a direct message there. Next, I'd like you to take a look at our vertical toolbar on the right hand of your screen. If you're not seeing it, you might have your event feed open. If that's the case, please exit out of it on the top right corner, and you should now find a toolbar and see the icons for the chat, the Q&A, polls, and the resources. Please use the Q&A feature to submit all of your questions and to vote on the questions you're most interested in. Our presenters today will try to respond during the presentation but via the feature, but they will also leave some space at the end to go over any remaining questions. Finally, if you need to step away, our wellness room is accessible. So if you exit out and over on the left-hand side of your screen, you'll see the icon for the wellness room. Okay, that covers everything. With that, I'd like to hand it over to our speakers, Gina and Megan. Gina and Megan, welcome.
Thank you so much for having us, and thank you all for being here. We're very excited for this opportunity. So my name is Gina Capidu. I get to be one of the program coordinators with Kids Mental Health Pierce County. We provide technical assistance in rolling out the Kids Mental Health Washington model across the state. I think a big piece of my why and why I do this program is I've worked in a lot of rural settings. I've also worked for a Department of Children, Youth, and Families doing child protective services work, and I just see how core mental health is for youth. And then having grown up in the foster care system myself, I have a really deep passion for intersectionality. And so I'm really honored to be able to bring a bunch of different partners to this work and really look at youth and family wellness holistically. And I'm very excited to turn it over to my partner, Megan Hopkins. Megan, go ahead.
Thank you, Gina. Good morning. I am Megan Hopkins. I am a licensed mental health counselor who's worked in clinical practice and in school settings, supporting youth with trauma, mental health, and neurodivergence. I'm currently the Youth Mental and Behavioral Health Program Manager with Washington State's Developmental Disabilities Administration, which is a division of the Department of Social and Health Services. My work is centered around increasing access to mental and behavioral health supports for youth with intellectual disability and developmental disabilities along the entire continuum of care. In my professional sphere of working with neurodivergent youth and children and youth who experienced trauma, I've encountered a system of care that was not equipped to meet their needs. In my own experience of parenting two neurodivergent children and supporting friends as they struggled to navigate mental and behavioral health care for their children, I witnessed a system that is simultaneously complicated and unprepared for the complexity experienced by many youth and their families. I was drawn to working on developing Kids Mental Health Washington, the program Gina and I will describe to you throughout this presentation, because of the family-centered, holistic approach to supporting youth and their families. This program offers possibilities for supporting children and youth in accessing appropriate care, for supporting families in navigating complex systems, and for addressing system disparities to build a more equitable system of care. The teams that make up the Kids Mental Health Washington program give me hope that families can experience the support and validation that they need.
Awesome. Thank you, Megan. And so I'm going to turn it next to our land acknowledgement slide. And for us, we are here in Washington State. And in Washington State, we really just want to acknowledge all of the tribes within our state, those that are federally recognized and the tribes that are still fighting to be recognized by federal government. And we want to acknowledge the people and the communities that have lived on and cared for these lands since the beginning of time and continue to do so. And this land acknowledgement is just one small step towards true allyship. And we are committed to uplifting the voices, the experiences, the histories of the indigenous people of these lands and beyond. And so it's important to us stress that as this is a virtual space, we want to honor and thank the ancestors and the leaders who have been stewards of these physical lands and waters since time immemorial and have committed to caring for the lands, the waters, the plants, and the animals here. So we encourage all of you that are at home, at the office, or where you may be literally in the country to take some steps on your own of learning about the Indigenous people who have inhabited and continue to inhabit the land where you are yourself right now. So what we'd like to do next is turn it over to hear a little bit about, we wanted to go and hear a little bit from you all about where you're at. So if you could, in the chat, please put down like what county or state you're coming from, or even possibly both. We know there's lots of people coming from all over, so maybe you'll find some new neighbors. We would also really love to see what space and what system you're representing, whether that's going to be social services, community behavioral health, maybe you're a public health administrator, just to get an idea of who's in this room. And then lastly, we would love for people to start dropping in the chat, or what are some of those biggest barriers that you see in addressing youth behavioral health? And specifically, when we're talking about youth behavioral health, we're really focusing today on kindergarten through 12th grade. So if you want to go ahead and use that Q&A or that chat box, I'm already seeing that we've got people coming in from, it looks like Illinois, Texas, Kentucky, Florida. We're hitting just all parts of the country, which is super exciting. We've also got a really wide and diverse representation of who's in this room. So people with disabilities, children's mental health. Looks like we've got some county government, some early intervention specialists, some more community health, juvenile mental health court. So we've really got a good breadth of partners, and that is really the key of what we're going to be focusing on for our model today. What's important for Kids Mental Health Washington, what makes it impactful and effective, and we'll dive into that deeper, but what we really know is that it's leveraging these systems. And by these systems, I mean you, because systems are made of people, right? And it's those relationships and having coordinated information sharing, collaboration that really leads to change for families and accessing the entire behavioral health spectrum. And so for us, what we're thinking about is how busy it can be for families trying to find a provider for their youth, right? Trying to navigate the system, trying to do the forms, trying to keep their head above water with whatever else is going on with home, with bills, with their own physical needs. And for us, if you could have all of these partners, including those on this call from all over the country, all the different professions, all the experiences we have in one space, what could be? Right? And so that's what we're really going to talk about is the what if that happens from this, where we're not only making sure that we're accessible to the families and the youth that are looking to access these services, but that we're learning from each other. So we're building that professional capacity as well. So thank you all so much for telling us a little bit about who's in this virtual space today, where you're coming from, and just the skills that you bring. So being mindful that everybody's coming from a different space with different experiences, literally all over the country. One of the things that we wanted to get grounded in today is just kind of a snapshot of what's going on in Washington State with behavioral health, which we expect is happening to be seen all over the country in all the different sectors. And I think this quote really captures it pretty well, that a child's current behavior often reflects an essentially sane response to an untenable set of life circumstances. And when we look at our youth and our families today, they are living through some really untenable sets of life circumstances, as are the providers that are doing everything they can to meet the needs of their communities. Here in Washington State, one of the ways that we frame that is on March 15th of 2021, and it's hard to believe it's already 3 years ago, but our Governor Jay Inslee signed an emergency proclamation recognizing the current mental and behavioral health emergency among Washington's children and youth. And what we know is those emergencies for behavioral health, they're not going to come in just one form, and they're not going to fit in a clean little box. And as a result of that, it is so important to recognize that there's not a single partner or system that's going to be able to own full responsibility, and nor should they, to be able to address all the multi-factored pieces that go into having a healthy system and holistically looking at kids and families. So when I think of the groups that are here, it's not just the county, right? It's not just the early interventionists. It's not just the VA. It's going to be a wide group of people. And with that, we wanted to give a little bit of history also. So with this model, with Kids Mental Health Pierce County, our backbone organization is Mary Bridge Children's Hospital. And when we're talking about 2021, and we're thinking back to 2020 when we had COVID, of course, even before that, in our emergency department, we were seeing a 400% increase in youth being seen in our emergency department for behavioral health needs. And so what that tells us is that the acuity and the frequency is continuing to grow even before COVID in 2020. But really, all of our work usually starts with a story, right? There's one family, there's one event, there's one circumstance. And the way that this came about for Kids Mental Health Pierce County was here in our emergency department with Mary Bridge Children's Hospital. We had a youth that came from out of county that had some really intense behavioral health needs, as well as intellectual and developmental delays. And this youth was brought to the emergency department because the community and the family didn't know how to keep this youth and the community safe with where the youth was. And what happened is this youth ended up living in the emergency department, boarding in the emergency department for weeks at a time. So when we're talking about a youth that was already in crisis, that really had a need for structure and stability, taking that youth and having them stay in an emergency department that's got staff that are changing with shifts. It's very loud. People are there for other issues. And what happened is this youth was here for several weeks, which in itself is traumatizing, but it also led to staff injuries and hundreds of thousands of dollars in unreimbursed expenses. And so Mary Bridge said, there's got to be a different way. There's got to be better ways that we can support this youth, that we can access earlier services upstream for preventative measures and lower level interventions. There's got to be ways that we can support pulling on our community. So what are we going to do? So we had a few $100,000 that were invested from the Mary Bridge Foundation. And with that foundation money, we held our first youth summit, and we invited over 70 different stakeholders from the community in every sector imaginable. We had law enforcement, first responders, we had EMS, community behavioral health, Department of Children, Youth, and Families, which is our Child Protective Services agency. We had peer partners, we had families, we had parents, we had youth, we had a really diverse spectrum of partners that came together. So what's behavioral health look like in your system? What's it look like in my system? What are some of the trends that we're seeing? What are the gaps? What's the data? And with that, there was a program manager who is now our director. Ashley is my supervisor of Kids Mental Health Pierce County. And we came together as a community and said, what can we do to make the services more accessible? And how can we all partner better together? Because what we know is there's workforce capacity issues all over the country. I heard about this during presentations yesterday. I can't magically have a bunch of trained clinicians enter this workforce, right? And I can't create more inpatient facility beds. I can't address on my own the funding cuts. But what we can do is get out of the silos so that we can strengthen our referrals, we communicate better, and then we can get upstream for families and youth. So for Kids Mental Health Pierce County, this is a coalition that really emerged from that community collaboration of 70 plus partners coming together for this summit and said, this is not just going to be a juvenile justice youth, a foster care youth, a school youth. These are all of our kids. So what we're going to do is we're going to have a multi-system level of impact. And that is what Kids Mental Health Pierce County is. And specifically, we're focusing on youth that are kindergarten through 12th grade, that are school aged. It is regardless of what their insurance status is, which is a really big win when so often insurance dictates what kind of access youth and families have, what kind of providers can be reimbursed for the valuable services that they're doing, and all those other systemic pieces that tie in. And what we knew is that there was a lot of research and a lot of partners that were doing 0 to 5 and then post-secondary, so the 18 and up. So we really wanted to focus on this kindergarten through 12th grade. What was also important to us is that as much as it was about not having to have insurance dictate how you get services and support, it was also going to be about what status of documentation these youth were, what they were going to be served, whether they were citizens, whether they were immigrants, or anything in between. So that was really critical, is we as a community had an agreement that said all of us are going to come together. We're going to partner and support these kids. And that's critical because when we look at some of the data, we know from CDC numbers that 1 in 5 children and youth may experience a mental health disorder every single year. Nearly 70% of the youth that are in juvenile justice systems have a diagnosable behavioral health disorder. And we definitely know there's an overrepresentation of children and youth of color, or LGBTQIA children and youth, youth, those that are living in rural areas, and those with intellectual and or developmental disabilities that are going to be at just an increased risk of mental health concerns because of systemic racism, sexism, homophobia, and other types of oppression and marginalization. So for us as a community, we said we need to address these things, because what we also know, just with recent study we have here locally, is that there's fewer than 1% of youth that are ages 11 to 18 that are actually enrolled in Apple Health to also get not just mental health services, but substance use disorder treatment. And we know how co-occurring that those can be. So we really wanted to look at that. And we also know that we can't keep having kids come to emergency departments, because not only is it traumatizing, what we also know by doing some local research here is that only 35% of the kids and the youth were able to get follow-up care within 7 days of being seen at the emergency department for a need. And within that, only 23% were able to get care within 30 days. So we've got the statistics, we've got the anecdotes, and we've got the community willpower. So the next piece is what are we going to do about it? Well, what we're going to do about it is we're going to look at it from a holistic lens. We're going to look at who are these kids that we're serving that have intellectual and developmental delays. Do they live in a rural area? What kind of family supports do they have? What kind of community resources do they have? Because providers are going to vary physically based on where they're at, based on insurance, all those pieces we spoke to. We also have to look at what's going on in their environment at large. Our youth are seeing a wave of technology access. They're seeing a lot of youth violence. There's widespread generational conversations about addressing mental health and stigma. And then we as a society, what's being driven as legislation? What kind of social movements are happening? And so looking at all of these pieces is critical. It has to be a multi-component model, which we're going to dive into the aspects of really shortly, because of the complexities and how interwoven all of these things are. And with that, one of the things that was also important is the only way you can look at things holistically is by working holistically. So you need to have all of these different partners. And these are just a few partners that are engaged in Kids Mental Health Pierce County, Kids Mental Health Washington, and rolling this model out statewide. And as you'll see here, we've got health equity partners, primary care, our juvenile justice, our managed care organizations, the insurance companies that oversee the Medicaid youth distribution of services. So it's really going to take a cross-system approach. And one of those cross-system approaches actually goes into talking about the model itself, right? So what are we going to do to address these pieces? And then I can turn it over shortly here to our friend Megan about particularly the populations that we were intentional when we stood up this model to go statewide about. So here in Kids Mental Health Pierce County, this is the model that is going statewide across 10 teams throughout Washington State. And what it really consists of is 3 big pieces. The first one is a steering committee of local resources and collaborative partners for community initiatives. These are governing high-level people that are able to make decisions to commit agency resources. And they are the ones that are working together across all those systems, the partners you just saw on the last slide, to say, or what are we going to do about being able to serve kids and families so that there's a no wrong door approach. The second thing is that we hold what are called multidisciplinary team meetings. And with those multidisciplinary team meetings, it's bringing all those partners at a table. So I talked previously about what it's like to have all these different providers try to make all those phone calls. Well, what if you had all those partners that were on the screen show up in a virtual space for you that you could access anywhere? And if you don't have internet accessibility, what if we were able to bring all these partners to you in a physical space, whether it's a high school or a community center, and we do that. So if families have some needs for safety planning, if they need outpatient navigation, we bring providers together in a space with the youth and the family, and that's critical, is that the youth and or family is at these meetings. So they're the ones telling their stories, they're the ones hearing the information, and the community showing up with them and for them. And then the last thing is our families tell us they don't need another door to another empty room, you all. So what we need to do is have a current localized hub of resources that is constantly up to date with who are my local providers, what information is there about how to access behavioral health laws and treatment modalities, and how can we do some workforce development for our providers that are doing this great work. So this is the model of Kids Mental Health Pierce County, and it's been seen to be very effective in keeping youth out of emergency departments or reducing their length of stay when they come in for a behavioral health emergency. We've also found it to be really effective at getting upstream and increasing provider workforce retention and recruitment. We've also seen it be really effective in making sure that it takes families fewer calls and clicks to get to where they need to go sooner. So when 2021 hit shortly after COVID, and everybody was saying that youth behavioral health was on the rise, the state was looking for what are some options and how we can address this. And Kids Mental Health Pierce County, with it being so effective and community-led instead of top-down, was seen as a model that could actually go statewide. So with some legislative funding, we were able to start expanding this model statewide. And we've seen some really impactful pieces. And part of that is driven by key partners, which I'm going to turn it over to Megan here. So this is done in partnership with the Healthcare Authority and with Developmental Disabilities Administration here. And that's our role here at Kids Mental Health Pierce County, is take these model components, take that data, and be able to train and support through technical assistance 10 teams that are addressing youth behavioral health and implementing this model locally across the state. What's really key for us is they are not replicating this model. The needs that I have in maybe Central Washington is going to be very different than Eastern Washington, Northern Washington. It's going to look different from an urban setting to a rural setting. So there's those pieces where they're able to have the pockets of brilliance where we can take this model of Kids Mental Health Pierce County, replicate the model aspects locally, but what can we learn from the 10 teams across the state doing this that can also be influenced across other regions and also be able to influence us here in Pierce County? And also what we want to do is collect data, right? How do we have the numbers that's going to drive policy change and some reform with the system partners? And one of the things that I'm really excited about is being able to impact families and youth at that direct level with these behavioral health navigator teams that are supporting the families, implementing those model components, but also leveraging really key partners like Megan, who I'm going to turn it over to, that's able to say, we're going to be able to transform some agency experiences for families. So Megan, I turn it to you.
Thanks so much, Gina. And, I just want to chime in on that last piece of the collaboration of the state systems and all of the regions, the way that the model really simultaneously has some centralized, standardized support, but also customization in the region. And the critical role that Gina and her team have played in the development of that program and the balancing of those two aspects. So having identified a technical assistance team has helped the regions develop relationships with each other and with system partners in a way that would not have been possible if all the regions were working independently. So not only do they provide logistical support, but they offer a bridge for connection, for information sharing, for shared learning, and for gaining statewide perspectives on trends and needs as they arise. I cannot tell you how many times I have felt gratitude for Gina and her team at Kids Mental Health Pierce County. So one of the things that I really appreciate about the Kids Mental Health Pierce County team is as they were looking at the folks who needed to be at the table, they included developmental disability partners, which is often forgotten in other aspects of the system of care for mental and behavioral health. But their inclusion of the Developmental Disabilities Administration has had an amazing impact in multiple ways. So in Washington, the Developmental Disabilities Administration provides home and community-based waiver services and residential services for individuals with intellectual and developmental disabilities. The state Medicaid structure for children places mental and behavioral health supports in the realm of Medicaid managed care plans and habilitative support in the realm of DDA. Children are whole beings whose needs cross system delineations. So collaboration among system partners is essential to supporting families and navigating the services they most need for their children to live and thrive in their communities. At DDA, we now have several positions participating in the development and delivery of Kids Mental Health Washington. As the Youth Mental and Behavioral Health Program Manager, I'm the Kids Mental Health Washington Program Lead. I work with Kids Mental Health Washington teams to understand their experiences and needs around supporting youth with intellectual and developmental disabilities and their families. I'm working with teams within DDA to build the infrastructure that's needed to be responsive to youth who have a dual diagnosis of intellectual or developmental disability and mental health needs, or whose externalizing behavioral presentation is complex. We have hired 3 youth behavioral health specialists, 1 for each of our DDA regions, to support our case resource managers in navigating complex systems of care and to participate as Kids Mental Health Washington liaisons, which looks like being active members of steering committees, multidisciplinary teams, and being available for consultation with the Kids Mental Health Washington teams. Our youth behavioral health specialists also bridge the gap between regional direct service staff and headquarters leadership so that we can all better support the youth who need the most care. Additionally, through our relationships with the Kids Mental Health Washington teams, we have partnered to support youth with intellectual and developmental disabilities and their families in navigating service systems by providing resources such as our Eligibility and Services Guide, doing trainings for Kids Mental Health Washington teams about DDA services and processes, connecting clients with specific resources, and communicating with system partners so that everyone has the most up-to-date information. The Kids Mental Health Washington program philosophy matches well with DDA's client and family-centered approach. The Southwest region shared that having DDA at their multidisciplinary team meetings when a youth is not already eligible helps families to feel less overwhelmed by the idea of applying for DDA eligibility. By having a real person explain the process, they're more likely to reach out for the help that they need. In the Greater Columbia region, an 11-year-old girl was discharged from the Psychiatric and Behavioral Support Unit of the Children's Hospital, but was experiencing another crisis and was at risk of rehospitalization because of not having adequate community supports. The Kids Mental Health Washington team convened a multidisciplinary team meeting with the child's parent, DDA, the school district, managed care organization, crisis services, and community mental and behavioral health providers in their region. Through that and subsequent MDTs, all of those systems collaborated to address the needs identified by the youth and her mother. Today, she's thriving. She continues to live in her family home. Her school days are getting longer and longer. Their home received the modifications they needed to support her sensory and safety needs. The stress on her mother has decreased, and she's able to engage in community activities like going to the trampoline park. In the Pierce region, DDA participation on the steering committee has contributed to system improvements through shared knowledge and collaboration on local initiatives. As the program continues to evolve, we are working together to address disparities in the system of care. The Kids Mental Health Washington teams are ideally situated to gather data about gaps and opportunities in their regions. Their relationships with providers create an opportunity for idea sharing that impacts culture and service delivery. DDA participates in this aspect of the program by sharing resources about the unique needs of individuals who are dually diagnosed with intellectual and developmental disabilities and mental health needs, such as our guidebook, and other training opportunities to increase the capacity of the workforce to be able to serve these youth. The crisis of youth who are boarding in the hospital is forcing us to address the inequities in our system of care. With the inclusion of DDA and Kids Mental Health Washington, we're collaborating to evolve the system together. Switch to the next slide, and I'll tell you about the rollout of Kids Mental Health Washington. Has a graduated rollout structure. So in the 2021 legislative session, lawmakers funded the existing Kids Mental Health Pierce County program and funded them to provide the technical assistance for rollout of other regional teams across the state, funding 3 regions per year for statewide coverage by the end of fiscal year 2025. The regions were offered the opportunity to self-select implementation order, identifying which year they would stand up their team. As you can see here, in the first year, July 2022 to June of 2023, Pierce continued their team and provided technical assistance and support to Salish, Greater Columbia, and Southwest regions as they stood up their teams. This year, which began July 1st, 2023, North Central, Spokane, and Great Rivers are stepping into the startup. During COVID and before the legislature funded implementation of this work, the Healthcare Authority wrote the program into the American Rescue Plan Act, or ARPA, seeking approval to stand up a version of the program in Washington. The ARPA funds became available in the spring of 2023 and are available through September of 2025. Thurston Mason region stepped up and agreed to start implementation this year with ARPA funds and will then switch to state funds next year when funding becomes available. Additional ARPA dollars went to year one regions to explore and pilot multi-county implementation because we anticipate that there will be different staffing needs in multi-county regions and look forward to learning from the year one regions as they explore this. ARPA funding was also used to support the web design and startup on Kids Mental Health Washington for incoming regions, and to support the amazing work of the technical assistance team as they continue to meet with multiple regions and hold learning collaboratives for all regions to learn from each other. And in year 3, King and North Sound will join in implementation, and I'm happy to say those conversations in both regions are already underway.
Great. Thank you, Megan. And so just a couple of pieces now that you've got a visual to kind of emphasize. What we know is that it's going to look different in every community. And as Megan talked to, there's going to be opportunities for the regions to learn from each other and to learn collectively and be able, as we roll this out on a graduated process and implement it locally, that we can kind of make sure that the model is customized to what the families and the communities need. This is going to be linguistically, it's going to be culturally how they access services, it's going to be utilizing the culture of accessing services, whether it's going to be an urban or a rural area, taking into considerations about technology aspects, insurance status, availability of providers, workforce shortages, wait lists, all those pieces, right? So we know those are all going to look very different in every area. But what we really wanted to also highlight is some of the data, some of the wins that we've had. Is what's been really powerful is so often when, funding comes available and a program gets started, the funder is the one that says, these are the metrics we want you to capture so we can see how you're moving the dial. What I think was really unique in part about this program was in this opportunity, it was actually the 10 regions that divide up Washington State. Each region has a team. Those teams collectively were the ones that decided how they wanted to collect qualitative and quantitative data to capture the story of behavioral health, whether that's access, whether it's acuity, whether it's workforce development, and they came up with the metrics and what they were going to be capturing on a monthly as well as a quarterly basis. They capture on a monthly basis the quantitative data and on a quarterly basis, that qualitative data. So those stories that are happening live on the ground. And these are developed by the regions, like I said. And some of the things that the regions that were important to capture was the age of the youth, the insurance type that they have, how soon they got in contact with the family after a referral was made, what kind of system involvement they have. So we want to recognize and understand intersectionality of developmental disabilities administration, juvenile justice, child welfare, all those other sectors that youth are often involved in, what area they live in geographically, so we can match it against maybe Department of Health data or Department of transportation data, so we can see where some of those gaps are and just see like what kind of ages are being served by whom, which partners, and what's the disposition of these youth. So what we know now is of those model components, some really important things have been happening. We've had about 200 multidisciplinary team meetings that have been requested by the teams that are hosting those. So those are the meetings where the youth and or the family are at the table, virtual or otherwise, talking about this is what we need, whether it's outpatient navigation, safety planning, behavioral management strategies, and you've got anywhere from about 4 partners to about 33 partners that are showing up on a call to say, we as a community are going to step in, we're going to talk about what's available, and we're going to do some community education. This averages for the partners that come to the table to speak with the youth and the family is usually about a dozen or so. Most commonly, these partners are coming together on a scheduled basis. So these are happening about once a week where all these partners are designated to be there, where the community has said this is important, we're going to show up, not only to show that we can provide resources for families, but so that we can learn from each other. And what's been really powerful is they are on scheduled basis so that we can just respect the limitations of everybody's busy and people have many demands on their calendar, right? But also what's been powerful is they can pull these multidisciplinary team meetings together on an ad hoc basis. So even on one instance, there was a holiday weekend where we had within 3 days, a referral came in, our program coordinator reached out to the family, figured out what was going on, put out the request, and the community came together within 3 days, and there was over a dozen partners. And this was on a holiday weekend. So really what's happening is the community is coming together, but even though our program serves the entire range of kindergarten through 12th grade, when we look at who's actually coming to the table seeking supports and services, it's really served everywhere from 5 to about 18, but on average, we're looking at that about 11 to 12-year-old age range. And what we do know is when we're looking at the breakdown of like insurance status, it's actually about half and half. About half have Medicaid or publicly funded insurance, and the other are about private. And so it's a pretty even split that way. And what we also know is when we're looking at what families are requesting, the most common things that are being requested from these multidisciplinary team meetings are outpatient service navigation, care coordination, behavioral health management strategies, some transition planning, especially if they're going to be leaving emergency departments, juvenile justice, maybe an inpatient facility, and then also safety strategies. And these referrals of like, how do we come together as a community to have an MDT most commonly are coming from schools, system partners, and the parents themselves. And to us, that's really an indicator of community trust and community investment when it's the partners and the families themselves that are reaching out and requesting this. So what comes out of these meetings is you get about 1 to 2 dozen recommendations per multidisciplinary team meeting. So all the partners with the youth and the family say these are some services or supports that we think could happen. But what's also really powerful is they're not always clinical recommendations. I see in the chat that there's going to be limitations on workforce, wait lists are really loud, but that's not always going to be what's going to happen for supporting a youth and a family most holistically. What we've also seen come out of these meetings are scholarships for boxing classes. We've also seen recommendations for boys and girls clubs or after school programs. We've seen gas cards so that families that live in really rural areas are able to drive to a provider. Because what we know is it's not always going to be a circumstance where it needs to be a cognitive behavioral health therapy or it needs to be an inpatient facility. Sometimes the actual treatment is just having community to be able to provide those supports at a lower level so they don't get to the inpatient or the emergency department. And what's also really critical is looking at how we support the entire household. So one of the key partners that attend all over the state for these multidisciplinary team meetings are those systems. We've got Child Protective Services, Developmental Disabilities Administration, but we also have community-based behavioral health providers. We've got school counselors. We've also got peer partners, so parents that have themselves often navigated these systems if they have a youth themselves that have intellectual or developmental delays that they've cared for, to make sure that it's not just the youth, it's the family, looking at that holistic process. What we also want to do is make sure that the services that are coming out of these meetings are really culturally and linguistically responsive. So making sure that we're actively seeking those providers to be at the table and looking at what can they offer so that services feel good to families. And what comes of that is there's so much information that comes to these families. The attendees of the multidisciplinary team meetings are really those that are tailored to what the ask is, so it's not overwhelming. We know it could be really traumatizing to retell your story to a group full of people. And what comes out of that is these recommendations are documented by these Kids Mental Health Washington teams, and then they're shared with the family, so the family just has to show up and be present. All the notes, all the recommendations, all the contacts are in one place on one sheet from one person. What we also know is people get busy, referrals get lost. And so the Kids Mental Health Washington teams are that liaison with the family that say, hey, we had this meeting. Have you got connected? And if not, what's the barrier? Did you not get a return call? Well, we've got that relationship because it's all about relationships. We can reach out and facilitate that. Were you just so busy that you didn't have time to make calls? Maybe we could do that. Was the paperwork so overwhelming that you needed some assistance with the application? And they can do those pieces. So those have been really, really critical. And those team members that are facilitating these meetings, they're also doing a lot of the behavioral health navigation work themselves with the families. And that could be really broad. It can be attending an individualized education plan or an IEP for a youth to get special support services within the school district. Maybe the barrier is that the family doesn't have insurance. Well, we can help families get access to Medicaid and state-funded healthcare insurance. And maybe sometimes it's just you don't have that relationship with a provider or you're too overwhelmed to make a call. Well, if they're going to be part of our steering committee and they're listed on our website as a resource, we can pick up the phone and we've got that relationship and we can help streamline that access. So those are some of the things that come out of these meetings. But what's it mean to the families? What we hear from the families that I think speaks volume is every single one of these multidisciplinary team meetings that are held. Like I said, we had about 200 requested. About half of those actually end up in multidisciplinary team meetings, either because the behavioral health navigator teams from Kids Mental Health Washington are able to meet that need with a phone call or a consultation. But we want to be really respectful and good stewards of the partners' times. So making sure that we're not pulling a meeting together, which in itself can be a really big thing for a family to process and make time for. for, but also we want to make sure that when we get to that place and we're kind of stuck and we need community collaboration, that we can do that. But not a single one of those MDTs happens without the youth and or their family there, because you can't do this work with families and about families without them literally being at the table. And that's having them in those case planning discussions, but also having that peer and that partner voice at the table. And what we're hearing from the parents is that they do believe that this is a great approach, that from a parent's perspective, this is something that's absolutely needed. And I think something that's really powerful that we got a quote from is just thank you to everyone for being here when my daughter and I needed you. I don't have words to express how much weight's been lifted from both of us, and having this resource, which was the MDT, to help point us in the right direction, come up with ideas to get my daughter on the right track has been invaluable. Something else we want to recognize is not always when a family comes looking for a resource is it something that exists or has capacity. But what we do see is that having these meetings and having community partners come together provides families hope to keep going in a really complex system. Megan and I, we're professionals. We do this work day in, day out, navigating this system, and it's overwhelming for us, let alone for a family that doesn't have the training and experience that we do and is just trying to keep their head above water. So we hear about what's going on from the families. We've got some of the numbers, that data that I talked about that the regions are collecting themselves. But what we also want to look at is the impact. So what we've seen is across Washington state, there is a 0.1% sales tax that is being used to leverage behavioral health services across the state. That's coming up in various counties. And what we've seen for the regions that have counties that have this is they're able to influence that by collaboration through the steering committees of all these different systems and sector partners. They're able to say, we're not going to fight over funding. We're not going to be duplicative in our services. What is the gap and how are we going to address it? Is that creating a new program or is that expanding capacity of somebody that has it? And that's by being able to influence these state dollars. That's been really effective. There's also been a lot of expansion of bringing evidence-based programs into schools. So that's something that we've seen go really well. Also, another core value, like I said, we can't do this work with families without families and youth, is having paid opportunities for youth to sit in on these steering committees so that they get the experience and the direct insight opportunity to say, this is what's going on in my school, my families, my communities, and being able to incentivize that participation because it is so valuable. I keep coming back to, and it's because it's so true. I know here in the state, but also across the country, is not everybody has internet access. And so what we're doing is through community collaboration, our Southwest partners in the south part of our state, for example, they're helping partner through their steering committee in creating a telehealth hub. What is a central physical location that rural families can access where they can get internet access and computers so they can tap into multidisciplinary team meetings, so they can access behavioral health virtual services, so that they're able to have a more local opportunity to be able to get what they need. We're also looking at how do we streamline communication so that all the partners, when there's a crisis for a youth, whether it's suicidal ideation, whether it's self-harming, that there are standardized county-wide processes in place of how we're going to support these youth in crisis without them going to an emergency department if that's not where they absolutely have to go. What we're also seeing is families are able to access information a lot higher and a lot faster by using these local regionalized hubs of resources, which we'll show in just a second. And with those opportunities, what we're seeing is that there's traffic that's being driven here already with how much these regions are coming online and they're building out their websites. We have anywhere from about 760 local visits on each regional website that is standardized to their resources and their partners, up to about 11,000 hits every single month. So we know the community's using this. What we're also seeing is that the regions, including ourselves as Kids Mental Health Washington, that is the hub that holds all of these regional partners, is that we're able to train partners with CEUs, whether it's offering webinars about youth and racism, whether it's about information about what is family-initiated treatment and other laws that exist in Washington State for behavioral health and youth, but also being able to host conferences where we're providing school-based educators, CEUs, to learn about neurodiversity and other topics that pertain to youth behavioral health. So when we're looking at, these are some of the wins, these are some of the impacts, this is what we're seeing locally. What we're really excited about, as Megan alluded to previously, is it's going to be truly statewide when we get that King County and everything north of King County to come online this July, stand up these model components and implement these differences locally. So with that, we wanted to just kind of answer some of those frequent questions, show you the resources, and then leave a few minutes for questions also. I also saw this in the Q&A, is how are youth with or without lived experiences going to be part of this initiative? Everything from the planning, the development, the launch, the implementation. And we've spoken to that a little bit. That I think is important to call out is, again, we have 100% caregiver and or youth attendance in these multidisciplinary team meetings. They do not happen without the families because it is about them and for them. They participate in our steering capacity, whether it's with a stipend for like our youth representation, like our friends in the Salish region are doing, or we've got parent peer partners that have lived experience that are at our steering committees, at our multidisciplinary team, and that we're referring to on a consultation basis, but also by listing their resources on these regional hub websites. And when we talk about parental involvement, I think that speaks to that aspect too. And we know that, this is a national conference, and so you might have different acronyms or different programs. But Megan, maybe do you want to talk a little bit about like how this is different from CLIP and WISE and MRSS and all the other acronyms we love in behavioral health?
Yeah, absolutely. And we don't expect you to know what any of those are. But just to give some background, Washington has several initiatives that aim to either facilitate the inclusion of youth and families in system development discussions, or programs that provide wraparound services or support system navigation. And Kids Mental Health Washington has a unique role in the system of care. So defining the scope of the program in relationship to the other programs has been a crucial aspect of program success. And then communicating that scope with system partners has also gone a long way to help all of the different partners to see how our programs are complementary and we can support each other through collaboration. And then there's the other question that we get often is, what are the new opportunities being navigated to? The program provides an opportunity to collect data, as Gina described, by developing and utilizing metrics that illustrate the current landscape of our system of care. Gaps and opportunities analyses are hyper-local and actionable. Cross-system team collaboration allows for being creative about supports in the community. It gives rise to innovative ideas to solving complex problems that come from having a variety of perspectives at the table. The program has an influence on statewide systems, such as Healthcare Authority and Developmental Disabilities Administration. And additionally, many of these teams participate in legislative work groups addressing system inequities that have the potential to impact statewide legislation related to the mental and behavioral health system of care for children and youth.
Absolutely. Thank you so much, Megan. And so what we also wanted to do was kind of encapture those websites that we talked about. We talked about the steering committee, some of the wins that have had impact across the state. We talked about multidisciplinary team meetings, and we talked about the impacts that come out of that. But this is that last component we wanted to emphasize. So in our QR code, if you want to pull up your phone and go ahead and snap a picture of this from your websites at home, you can do that. But also in the rack card, that's part of our program materials for this session. You can also access it, or you can go to kidsmentalhealthwa.org. And with that, what comes of that, or .com, excuse me, every one of these regional resources that have local providers, local experiences, local partners, they all link back to Kids Mental Health Washington. So there's really a no wrong door approach, but it's broken off by region, where some of the information you're going to find is, what are the crisis responders in my area? What kind of parent supports are there? What kind of intellectual and developmental disability resources can I access? What's the difference between inpatient and outpatient programs and the different levels of care across the behavioral health continuum? How do I find a provider? Particularly, how do I find a culturally relevant provider and a trauma-informed provider? We want to look at those. And then this is also where people can get access to information. For a lot of people don't know, at least in Washington State, that through your insurance provider, you might actually have a behavioral health case manager that you could tie into that can make all of these calls for you, or knows live the provider availability, so that you're not calling 30 different providers, leaving voicemails, and maybe getting phone calls back from a quarter of them, right? And so when you scan this QR code, what you're going to see is that map that I wanted to go back to. That's actually a very interactive process. And in that map, it looks like this one right here, and it's interactive in that you just look at the county that you're at, you click on this, and it's going to pull up that regional website. So maybe, for example, we have youth that live in Thurston Mason, but we have a children's hospital located here in Pierce, and I use Pierce because I'm Kids Mental Health Pierce County. Well, even though that they were seen in Pierce, they're looking for local resources in Thurston Mason. They would just click on that county, and it'll provide the local provider availability. And so you can see those aspects. And so what we've also found to be really important is we need these websites to be utilized by the populations accessing. So one of the things we have, and Megan spoke to, how we got funding from the legislator, is there's plugs that are built into this website. And this was not part of my social work education. So I'm very grateful. We have a website developer that gets to do this. And it can be translated into the most commonly spoken languages that exist within that region, so that helps enhance accessibility. But also just through that partnership and community collaboration, if there's someone that speaks a language that maybe we don't have a plugin for or isn't been translated to the website into, is we're able to partner through our systems and say, who has an interpreter, so that as this is all of our kids, all of our families, right, that we can be able to tap into a resource that makes that linguistically accessible. So what we wanted to do was leave a couple of minutes for questions. I see a few in the chat. What we also wanted to encourage is if you've got follow-up questions, Megan and I, we will stand on the soapbox all day if people will let us. We're really passionate about how this model has grown statewide. We've gotten interest from other states that have been really curious about the impact of this, how it's got opportunities of really being community leverage to take a model, but make it regionally specific, but also take those pockets of brilliance, as our healthcare authority partners say, and really expand those up and through statewide avenues to have systemic and legislative change. So this is who our team is. Our friends at the Healthcare Authority, Diana, Ruth, Edward, and our good buddy Jennifer, who we should also put on the slide. And then when I talked about that program manager, when Kids Mental Health Pierce County was just starting, that's our now director of Kids Mental Health Pierce County that oversees statewide. That's my supervisor, Ashley, our local Kids Mental Health Pierce County program coordinator, Vanessa, and then myself. And my role really with Kids Mental Health Pierce County is supporting the teams across Washington State that are standing this up. And our wonderfully fabulous presenter here today, Megan, and her boss, Shelly, as well as the 3 DDA workers that we're very excited to have literally at these tables with youth and or families. So Megan, do you maybe want to speak to, or do you want me to speak to one of the questions I see in the chat from Melanie about how we suggest getting more buy-in and their engagement from agency partners and stakeholders, including parent and youth representatives?
I was thinking that would be a great question for you to address, because I know that is a big part of the work that you did at Kids Mental Health Pierce County initially, and that you've been supporting all of the regions in doing.
Absolutely. Yeah. So I think a couple of pieces we've talked about, right? The paid youth time for our steering committee involvement, our parent peer partners that attend our multidisciplinary teams, making sure that the websites have youth specific resources and culturally specific pieces. I think another thing is we spend so much time, you all, being in the community. It's not about forcing the barrier of accessing care even more than it already is on youth and families. We need to go where the kids are. And so what that looks like sometimes is our very own Vanessa here in Pierce County on Fridays, I think it's every other Friday, she goes to a local youth space and she plays basketball and volleyball with the kids. And through that, the kids are drawn for the sports and the free food that is sponsored through like managed care organizations and local community foundations. But that's a very comfortable space where they start to facilitate conversations about youth mental health and what that looks like. Other things that we've done is we've partnered with school districts and we've hosted where the kids are. We've had summits and partnerships where we have performances with and by the kids, whether it's going to be hip hop therapy or the kids are doing raps about mental health. And so knowing what that looks like, sometimes it's going to be clinical, like bringing evidence-based programs like Hope Squad to our local school districts and expanding access. But sometimes it's really about going to the families where they're at and building that relationship and putting yet another barrier of access and care onto the kids and the families themselves. I think that's pretty huge. Another one I see here, Megan, is...
Yeah.
Oh, go ahead.
Yeah, I was just going to say there's another question in the chat about taking efforts to avoid burnout. And I think that's such an important question and one that we can answer individually. But I will just take a minute to talk about moral injury and moral beauty. So Gina is often identifies the experience of moral injury with our teams, right? So sometimes our teams are doing everything they can to support youth and their families, and they're coming up against barriers that we all have no control over. And that is hard. And Gina does a really beautiful job of validating the challenge of that. Recently, I learned about this term moral beauty, and I just love it because I feel like moral injury is the thing that impacts burnout, and moral moral injury creates burnout. Moral beauty creates resilience, right? So when we witness people doing things that uplift and support each other and that make our world better, it has a physical impact on us. And my experience of working with the Kids Mental Health Washington teams is of moral beauty. Every time we come together, there's something about having system partners join to collaborate that increases my experience of moral beauty. But it's not just that everybody's at the table, it's the tone and the culture that is created by these teams. And so some of that is about Kids Mental Health Pierce County and the way that they conceived of this program as a family-centered model that recognizes that importance of having youth voice at the center of the discussion. It's also about honoring the regions and their uniqueness and the way that they may need to customize what's happening for them, so that when everybody comes to the table, there really is this focus on how can I help, which is not always what happens at interagency meetings, right? And that culture is embedded throughout the entire program and is held and supported by the Kids Mental Health Washington teams. And so I feel like that piece of it is moral beauty, right? And it does help us with that resilience, that when we're experiencing moral injury from system challenges, we turn to each other and witness the way that we can show up together to make those system changes at the multi-levels, right? Sometimes we're impacting a youth or their family directly. Sometimes we're impacting the system, and we feel hope that we are able to influence system changes. And that also helps with resilience. But Gina, I would love to know how you would answer that question about burnout.
Yeah. And as always, we're right here, Megan. So the moral injury was a really big piece. And so I think having a name to moral injury, I highly encourage you to look into it. It's not compassion fatigue. It's not just burnout. It's the fact that we are representatives of systems that are structurally set up to fail families. And so having the language to say, I am experiencing moral injury has been so powerful in itself. Just being able to have those words, I think has been huge. We've also done a lot of trainings with our teams, and we also have it at summits where we have somebody that comes and does training about moral injury, so that there's actually like assessments and scales, because we're still clinicians a lot of the times, and we're able to look at where are you in your moral injury, where are you with burnout, compassion fatigue. So we've got a quantitative number, we can look at those, and then we can build in supports from the technical assistance aspect. Can I take doing some phone calls off of your plate? Can I take doing some website off your plate? You've got a billion meetings going on and you're preparing for a presentation. Can I facilitate a multidisciplinary team meeting? It's that communicative, collaborative partnership with technical assistance, and also that the regions offer each other. So once a month, we facilitate a learning collaborative with Healthcare Authority, Developmental Disabilities Administration, and all 10 of these Kids Mental Health Washington teams. And we take conversation pieces that are happening in real time and say, what is it that we need to focus on? Is it that we can't engage somebody from the hospital because the hospital is too busy? Or is it the fact that we're seeing a larger and larger number of the youth that we're serving on caseload longer happen to be those that were adopted? And what's that look like? And I think part of it is also that education, is we do webinars. So we've got information about what are the resources, what are the system opportunities and limitations. And when we don't have an answer, these teams are collecting data that is going to be utilizable to be able to say, this is the barrier, these are the recommendations that come out of it, and actually apply that so that accessibility is better for kids and for families and for providers. I think that's really a big piece. But what we've even heard from community-based providers is by having these webinars, by having these really neutral, collaborative spaces, that it actually does reduce their workforce turnover, because they feel like they're not alone. They've got the education, they know who to reach out to, and they know that if there are issues, there's data being collected to do something about it, not just be turned into a report and sit on a shelf somewhere.
So we recognize that in whatever state you're in or whatever system you're working in, you may not have the power to create a system like the one that we described today, but you do have the possibility to reach out and collaborate with someone. So I would love to see in the chat right now, if you would just take a moment and think about who could you collaborate with, whether it's a specific youth that you're looking at serving, or a system challenge that you're experiencing. Who is a person that you would collaborate with? And it doesn't have to be the specific name of the person, but somebody in your system of care that if you reached across the silo and were able to collaborate with, you might feel less alone in the work, right? It might increase your capacity, or you might actually be able to make some change. So if you go ahead and put those in the chat, who is somebody that you could reach out and collaborate with?
And thank you, Megan, for ending us on that call to action. I know we're right at time, so please use this contact information and maybe even let us know about like what you're going to do so that we can figure out how are you going to make a difference locally. So thank you so much, Megan, for presenting with me, Monica for having us, and all of you for being able to be here today and the work you do every day.
Yeah, thank you so much, Gina and Monica. Appreciate
Thank
it.
you, Gina and Megan, for your time, experience, and expertise with us today, and all of you attendees who joined us today. We will be taking a 30-minute break, and then we'll be diving into our final keynote panel discussion, exploring intersections of mental health and juvenile justice system. So please don't miss that. Thank you all again.
Thank you. Bye.